Hello everyone. Today I'll be talking to you regarding heart sound, JVP and murmur. They are the basic of cardiology and very important. Lot of questions you get in all the exam throughout the world. So before I really come to these topics, let me discuss some basic sites of auscultation. When we are auscultating the precordium, what is the location? Pulmonary valve, what we see. What is the location of this? Left second intercostal space at the upper sternal border. So if I say this is the sternum and this the second intercostal space, okay, so it is a left side, right side. And at the upper sternal border, definitely it is in second intercostal space. So that means it has to be on the higher side of sternum. This is the P. You can say P is the pulmonary. Then aortic valve, right intercostal space, second. That means this is the aortic. So you can say aortic and pulmonary are on the same level, but on the right and left side of the sternum. Mitral valve, left fifth intercostal space. Let's get fifth intercostal space. Okay, fifth intercostal space, mitral valve. Just this is the mid-clavicular line, and just adjacent to the mid-clavicular line on the left side in the fifth intercostal space is mitral. These are the second intercostal space. And finally, tricuspid, left fourth intercostal space, fourth, that means here. This is the fifth intercostal space, fourth, and just at the lower side of the sternum. This is the tricuspid. So, a quick recap. Aortic and pulmonary are in the second intercostal space, just right and left to the sternum. Tricuspid is in the fourth intercostal space, just adjacent to the sternum, in the left side. But mitral valve is in the fifth intercostal space, but it is at the mid-clavicular line. With this very essential information, now let me show you the actual picture also. So now you can see same what I told you. This is the pulmonary in the second intercostal space on the left side. Aortic is in the right second intercostal space, just adjoining to sternum. Tricuspid is somewhere in the fourth intercostal space, just adjoining to sternum. But mitral valve is in the fifth intercostal space at mid-clavicular line. Point to be noted, only one finding which is on the right side is aortic. Only one which is not near the sternum but away from sternum is mitral. Rest all three are quite near to sternum. Okay, and the A and P, they are in the left intercostal, they are in the second intercostal space. This is simple, very important information. With this background, we'll talk about heart sound. So let me tell you, well, we are all well aware S1, S2, S3, S4, what we write in short. First sound as S1, second heart sound as S2, 3, 4. Now this S1, it is produced due to closing of tricuspid and mitral valve. Okay. S2 is due to closing of aortic and pulmonary valve. So that's very simple thing, everybody knows, but still my duty to inform you. So look into this. So we have a mitral valve, we have a tricuspid valve. Okay, when these valve will close, they will produce S1, and we have a aortic valve and pulmonary valve. When they close, they will produce S2. With this small basic information, Now we take one by one. First heard sound S1, as I told you, produced due to closing of mitral and tricuspid valve, and they are at the loudest at the mitral area. And now I don't need to tell you the mitral area is in the fifth intercostal space at the mid-clavicular line. Now, what are the causes of loud S1? Mitral stenosis, tricuspid stenosis. Point to be noted, both these valves, due to which this sound is getting produced, if they are narrowed down, they can lead to loudness of S1. Tachycardia, any reason of increased heart rate and short PR interval, they all lead to loud S1. Okay. Then soft S1, bradycardia. Point to be noted, when tachycardia was there, it was loud, and bradycardia, when the heart rate is slow, that intensity of sound is reduced. Mitral valve calcification, again a very important point to remember. Mitral stenosis as such is a cause of loud S1. But even in the mitral stenosis, if calcification occur, then it becomes soft. Mitral regurgitation will again lead to soft. Due to same TR also lead to soft. Point to be noted, MS and TS, they were causing loudness, and now if they are regurgitant, then the sound becomes slow. Prolonged PR, point to noted, short PR was the cause of loud S1. In fact, many of things have reversed. Tachycardia loud, bradycardia soft, MS and TS loud, MR TR soft. Short PR interval was loud, and prolonged PR interval is short, is soft. Now we talk about second heard sound, S2. This is due to closure of aortic and pulmonary valve, which I showed you in the very first slide. Right. Loudest at left upper sternal border. Right. So if I have to ask you, okay, at what place, it's more of a left sternal border. That was the primary area of pulmonary. Remember? I hope you remember that aortic area was in the second intercostal space on the right side of the sternum. But this second sound we can hear makes best at the left upper sternal border. That means you can say roughly in the pulmonary area. This is a very, very important point to remember. Now let us see how is the normal splitting of the second sound is usually splitting occurs. S1 is usually together one, that's why we never talk about splitting. Okay, although there are two valves, but they almost occur in a synchronized way, but not this in case of S2. So that's why we have to spend more time in understanding S2, splitting, etc. Let us see. So in S2, we have two components. One is aortic, so-called A2, and other is P2, which pulmonary component we call as P2. So what happened? As I told you, splitting is there. This is the S1, A2, P2. This is occurring in inspiration. But in expiration, A2 remains there, but P2 comes closer. That means this is narrowed down. Point to be noted, this you can see, and this you can see. Agreed? A normal A2-P2 interval is around 30 milliseconds. 30 milliseconds. Well, now let us understand the reason why this is happening. This is very, very essential for the future discussion, that why in inspiration is a more gap is there. In expiration, less gap is there. One more thing you got to understand, that A2 component remain the same position. It is P2 which is shifting. Now, let me clarify what happens. Suppose the person is taking deep inspiration. So, during deep inspiration, more and more blood come to right side. Right side get more blood. So, in next systole, in the systole, more amount of blood will go into pulmonary artery in inspiration. So, P2 will be closed later on. But when it is inspiration, less amount of blood come to the right side. Less amount of blood will go to the pulmonary artery. So P2 will be coming, closing early. So that's why in expiration, the gap of A2, P2 is less, and inspiration, it is more gap is there. So we understood this normal splitting of second sound. With this background of understanding that S2 has got two components and there is some variation in the gap in inspiration, expiration. Now let's talk about, you are listening for second sound. Can we can get single S2 also, only one. Tetralogy of Fallot is a very commonly asked question. Tricuspid atresia, pulmonary atresia, Eisenmenger syndrome, and truncus arteriosus. Now, if you look into this, all these are congenital heart diseases. Okay, and we are getting single sound, and there's a reason behind that, why it is there. Everything has a different mechanism, and detail you can see in my lecture on congenital heart disease. As of now, you just remember that single S2 is produced in this. Okay, you have to remember it. After that, soft S2. We are listening. Okay, in the previous section, in the previous slide, only one sound, there was no split, nothing, single sound. But here we are listening to S2, but soft. When? Calcified aortic valve. Do I need to tell you? In this, A2 will be soft, P2 will be normal. It will be soft. So in total, it will be less. Definitely, if the two components are, any one is weak, the sound will be softer. Calcified pulmonary stenosis. Pulmonary valve is calcified. Then now this, A2 will be normal, P2 will be soft. So overall, you can find the S2 will be softer as compared to the normal one. Loud A2, now reverse loud A2 in systemic hypertension and loud P2 pulmonary. Out of all these, this is the single most important. Forget everything, I don't mind, but don't forget loud P2 is pulmonary hypertension. And it has a special significance because once we commit in any condition, like maybe congenital heart disease or rheumatic valvular heart disease, P2 loud is the one finding clinically by which we can say pulmonary arterial hypertension has occurred. Wide and variable splitting of S2 we see in right bundle branch block and severe pulmonary stenosis. Okay, first I explain to you. Let's say in pulmonary stenosis, heart, this is the normal, A2 comes first, P2 come later on. Now pulmonary stenosis is there. Now it will take much more longer time. Blood is there, but now narrow valve is there. So blood will take longer time to go out. So that's why there will be the wide splitting, but it will be variable. Variable will be same as what we saw in normal. What was the normal? In inspiration, the gap was more, the expiration gap is less, but now it is wider. That means, other way around I can say, it is simply the exaggeration of normal phenomena. but the interval is, you can see both are increased. This is normal, this is normal, this is normal one. And now you can see same in expiration, the look into this normal, and this is same. So as I told you, it is simply what is happening normally, but it is exaggerated. The gap is more, is what we call as wide and variable splitting, seen in RBP and pulmonary stenosis. This will happen in any condition where the pulmonary component goes out. Same thing in RBP also, the pulmonary component is closed later on. Wide fix is a very simple, but it is a universal question, that it is wide fix, okay, no change with the breathing also. This is ASD, look into this. This was the splitting. It is splitting both inspiration, expiration. You can see no change. No change is ASD, fixed wide splitting sound. Reverse splitting is a very commonly asked question throughout the world in all the exams. Very, very important. P2 is important clinically. This is important for exam point of view. Reverse splitting, so-called paradoxical splitting of S2. First of all, we should know what is the meaning. P2 precede A2. P2 comes first. Normally A2 comes first and P2 come later on. Here it is reverse. P2 coming first and A2 coming later. This is so-called reverse splitting or so-called paradoxical splitting of second sound. And even the splitting is maximum in expiration, decrease during inspiration. This is also reverse. Normally maximum in inspiration and minimum in expiration is totally reverse. So now look into this. This is normal. This is normal. A2 coming first, P2 coming later on, and splitting is minimum in expiration, maximum in inspiration. But here, P2 coming first, A2 coming later on, and you are getting less, gap is reduced in inspiration, more in expiration. Compare it. This is the expiration. And this is the inspiration. This is the inspiration. Now you compare it. Yeah. So you can see this is so-called reverse splitting of second sound. But what is more important, causes. This is just to explain to you. In the exam, they talk only about causes. Okay. So this we see in left bundle branch block and aortic stenosis. Point to be noted, the previous one where we got a wide variable, it was RBB and pulmonary stenosis. Here it is LBB and aortic stenosis, totally reverse are. So parallel things are going on, RBB, LBB, PS, AS. Now I must mention about tumor plop. This one thing, it is seen in atrial myxoma. This is the one thing which is very frequently asked question. Okay, well, this tumor plop is a classical thing, a very commonly asked question. Okay, and it is a sound produced due to atrial myxoma, which can change the site also, and it can produce a even diastolic murmur also. Murmur also, mimicking like mitral stenosis. But this murmur is of low pitch as compared to murmur of MS, which is a high pitch. So friends, what all you have to remember in tumor plop. Number one, it is heard in atrial myxoma. Okay, it just comes after S2, just like opening snap, right? So it occurs in atrial myxoma. It can, because of a fall, a change in position, detail you can see in my lecture on atrial myxoma, where I have explained you all the mechanism also, but as of now, tumor plop is heard in atrial myxoma. It is a low pitch sound, comes after S2, resemble like opening snap, but opening snap is a high pitch sound is there, and it can also followed by a low pitch diastolic murmur can be there, just like mitral stenosis. It's in fact, it's a very important DD for mitral stenosis, but very simple, very simple. If you change the position, that means change the position, you ask the patient to turn around, right, left, or make him sit, this sound and murmur may even disappear also. So that's the biggest advantage of differentiating, and very easy way to differentiate from mitral stenosis. So carry home message is tumor plop seen in which condition? Mitral stenosis. What type of sound? It's a sound which come after S2, but it's a low pitch sound. It come in the same way, same place with the opening snap, which is a high pitch, and it is again followed by mid diastolic murmur, just like mitral stenosis. But this murmur is low pitch as compared to high pitch murmur of mitral stenosis. Now we talk about, so this was about S1, S2, now we talk about S3, S4. But before I discuss S3, S4, let me tell you some basic concept about cardiac cycle physiology. So I'll be talking to you what is relevant to S3, S4. So here is the heart. Okay, this is the mitral valve, tricuspid valve. When early diastole occur, there occurs diastole, means the ventricles are dilating, and immediately, and of course no need to say this valve will open. In diastole, the valve will open, and immediately the blood will come. 70% of the blood come from both the atria into the ventricles, and this is known as rapid filling phase of the myocardium. As I told you, 70% of the blood come into the ventricle from the atria. Now on this left side, on the left side in JVP, you get wide descent. We know very well that wide descent is produced in the JVP due to opening of the tricuspid valve when rapidly blood is entering into the right ventricle. Now on the left side here, normally no sound is produced. But if a sound has to be produced, it is third sound. That's why third sound is also known as filling sound. Filling sound. Okay. Well, so now I don't need to tell you that S3 is correspond to wide descent in JVP, a very commonly asked question. Both are getting produced in the early or so-called rapid filling phase of the myocardium. Well, near the end of diastole, this atria contracts. So normally when we discuss cardiac cycle, we normally talk about ventricle systole and diastole. We don't discuss atrial systole, because that is merges into the late diastole of the ventricle. Anyway, for easy communication, so atria is contracting against the late phase of diastole, and this will push remaining 30% of the blood into the ventricles from the atria. So this atria on the right side, the atria will contract, and that produces A wave in JVP. A wave in JVP is produced due to atrial contraction. Atrial contraction or atrial systole. Atrial contraction is a better word so that we don't confuse with the ventricle systole. So atria will contract and that will produce A wave in JVP. Now on this side, on the left side, there is no sound is produced. But if a sound has to be produced, it will be S4. So S4 and A wave both are getting produced due to atrial contraction. That's why this is also known as atrial kick. It is just like a football player hits the ball, football, like a kick. Here also atria is kicking the blood to go into the ventricle, and that so-called atrial kick is there, right? So now I don't need to tell you. S4 will correspond to A wave in JVP and S3 correspond to Y descent in JVP. Well, and again I don't need to tell you to the illustrious student listening to me, in atrial fibrillation, S4 will not be there and A wave will not be there. Okay. One more thing I like to make you understand right now. Okay. In atrial fibrillation, the amount of blood coming to the ventricle is reduced by 30%. 30% less blood will come. Why? In atrial fibrillation, only this 70% blood will come, this 30% will not come. So amount of blood coming to both the ventricle is reduced by 30%. So in the next systole, the amount of blood entering will be reduced by 30%. And that's one mechanism in atrial fibrillation why easy fatigability occur. Easy fatigability occurs. This is one may, of course, there are many more factors are there, but that you can see in my lecture on atrial fibrillation. But as of now, some basic concept I've told you that why S4 is getting produced and why S3 is getting produced. With this background of basic concept, so now I'll be talking about each one of them, and some of the point I covered also. There may be little repetition, but don't worry. The third sound heard in the early diastole during rapid ventricle filling phase. This you already have written also. This is also known as filling sound or ventricular gallop. This is a new word. Gallop. Ventricular gallop is a word and it has got special meaning about I'll be talking to you. It corresponds to Y descent in JVP. It is a low pitch sound. This is important. So extra point what we got is ventricular and low pitch sound. And it is heard best at the apex with the patient with left lateral decubitus. That means the patient is lying on the left side. Okay, left decubitus, or you can say he's turning around left side. Okay, this is, you try, all the students should try your left side, like, oh yes. When of course this you can appreciate better when you are lying on the bed. Tonight when you lie on the bed, try to turn on left side. Oh, then you say, oh, this is left decubitus position, what Dr. Bhatia told us. Now you remember it. Yeah. Now pathophysiology. We learned about S3. Okay. It is so we simply learned it is produced in the rapid filling phase of myocardium. But why? What is the basic pathophysiology? It is produced due to two reasons. Either forceful rapid filling of ventricle, that is normally is a normal or elevated compliance like MR. Mitral regurgitation. Okay. Well, this is the heart, and in MRs, blood goes into left atria in systole. In diastole, a very large amount of blood, the blood which has gone from LA, LV to LA, and of course blood is also coming from the lungs. So double amount of blood is coming to this LA. So now in the next diastole, double amount of blood will come back. So huge amount of blood is coming. So rapid forceful filling of the ventricle with a normal or elevated compliance. Even in a normal compliance also total normal, but huge amount of blood is coming. So that will produce a sound so-called third sound. Or already flowing, already the, like in left ventricle failure, already a huge amount of blood is there. In left ventricle failure, we all know there is increase in the end systolic volume. So now more and more blood comes in, and that will produce third sound. One thing is sure, ultimately whenever extra volume of the blood comes to the left ventricle is going to produce third sound. Okay, so let us see. This is nobody going to ask you, it is just to make you understand the subject. Everywhere they'll talk about causes. Whatever mechanism I'm telling you, usually they are not asked in all the thing. Even second sound, they are not going to ask you what is the mechanism of paradoxical second sound. Everything they will talk causes. Causes you should know. Now causes of third sound, it can be physiological. That means it can be heard in a normal person. Who normal person? Children, it is normal. Athlete, pregnancy, okay, in these they are normal. Mnemonic is CAP, cap. CAP, this is normal. This nothing abnormal. If you get the normal finding is there. Now pathological, so coronary artery disease, congestive heart failure I explained to you, mitral regurgitation again I explained to you, AR again I explained to you. Reason why in AR, again I told you anything which cause increased volume will be there. Increased volume will be there, that can produce, that will produce a type of third sound. TR, $1 million question. This will produce right-sided S3. Normally 99.9% never have heard there is something called right-sided third sound is there. Since it's not even asked in the exam, but it is there. And thyrotoxicosis, again due to hyperdynamic circulation, it can be there. But these two are not very important question. So, but don't forget this. Okay, out of these are the two most important and frequently asked questions. Cannot afford to forget congestive heart failure and MR. This you don't have to forget. Okay, of course, there are many other conditions also. This can be there. This can be heard in so many conditions, but list is huge. But you don't have to forget these two. Now, something extra point. Pericardial knock. This is a very frequently asked question. It is a third sound which occurs slightly earlier, okay, slightly earlier than what happened in the routine third sound. It is a high pitched sound. Point to be noted, the normal H3 is a low pitched sound. It is a high pitched sound. It is seen in constrictive pericarditis. Okay. So again, this is the heart, and we all know very well in constrictive pericarditis we have a thick pericardium is there. Thick pericardium is there. So in this case, early diastole is normal. So rapidly blood will fill, but after that, since the pericardium thickened or calcified is there, further expansion of the myocardium is not possible. So that's why you get a third sound which is very prominent, slightly occurring earlier than the normal third sound, high pitch, and we have given name pericardial knock. The pericardial knock, when you get, he's talking about constrictive pericarditis. But don't forget, it is a type of third sound, but high pitch and slightly occurs earlier. S3 is never heard in MS and cardiac tamponade. Why? Because neither in MS nor in cardiac tamponade, rapid filling phase is never prominent. Since the rapid filling phase is never prominent, so there are two conditions where S3 can never be heard. One is isolated MS and cardiac tamponade. S3 is never there. Fourth sound, we learned is a late diastole. We know it is atrial kick. We know it's also atrial sound, and it is a low frequency, low pitch sound, just like S3 is also a low pitch sound. It's a pre-systolic because it occurs just before. The extra word what we got is pre-systolic. It occurs just before the first heart sound. And I told you it is produced due to emptying of the left of the atrium into non-compliant ventricles, stiff ventricle. So when it will be produced, definitely it will produce only when every time atria is contracting. But S4 will be produced when it is contracted against a stiff LV wall, so-called non-compliant. Non-compliant and stiff are same. Non-compliant means rigid person. We do get rigid person. Okay, same thing. Myocardium get rigid, then only S4 get produced. The extra two keywords are pre-systolic, and it is the stiff LV wall or so-called non-compliant left ventricle. It will be produced. It corresponds to A wave in JVP, the point we learned, and it will be absent in atrial fibrillation. This point also you already have written. Again, best heard in apex with the patient left decubitus position. It is just like what we heard in third sound. Again, left side, apex, same as for also. Oh, both are in the left decubitus, both are low pitch. Then what to differentiate? This I am going to discuss in the coming slide. But one thing, it is never physiological. Point to be noted, S3 we got in many physiological conditions. The pneumatic was cap, children, athlete and pregnancy. But once S4 is there, is always pathological, always abnormal, regardless of age. Point to be noted that in S3 was normal in children. But it is regardless, even if a child is getting S4, it is abnormal. So friends, the key word are never physiological, left lateral decubitus, and always abnormal. These are the three extra points that you learn as compared to the description what I gave you. So now, I told you, this will be produced when there is sudden rise in end diastolic ventricular pressure caused by atrial contraction against a stiff wall. Okay, so wall is stiff, ventricle is not in a position to dilate more, and now atria is trying to push 30% of the extra blood. Definitely when it is extra amount of blood will be entering due to atrial contraction, that will be S4. And we should not forget the large amount of blood whenever came in the early diastole, it produces third heart sound, right? So with this background, we move causes. This is what is going to ask you. Mechanism, nobody going to ask you. Systemic hypertension, aortic stenosis, HOCM, hypertrophic obstructive cardiomyopathy, coronary artery disease and restrictive cardiomyopathy are some of the causes, condition where we can see S4. Of course, there are many more also, but they are very, very important that you got to remember. So, hypertension, aortic stenosis, HOCM, coronary artery disease and restrictive cardiomyopathy are the causes where we can see. Well, now something extra, gallops. Gallop refers to either S3, S4. Remember, the two extra sound, if they are, we call as gallop. Now in S3 we call as ventricular gallop is S3, and S4 is considered as atrial gallop. Agreed. Now we have a, so whenever you write, they may ask atrial gallop means S4, ventricular gallop S3. But why I'm spending so much of time? We have a term called summation gallop. When S3, S4 are superimposed on each other, this we call tachycardia. Now, before I really go to summation gallop, let me tell you about gallops. Gallop is the word when a horse walks. So, this is normals S1, S2. So what we got is S3, early diastole, and S4 is the late diastole, S2, S1. Yeah, they're diastolic. So S4 occurs just before S1, that's why we call it just before the S1. And this is the early diastole. So these sounds are just when a horse walks, they are produced like that. That's why they are known as gallop. But in tachycardia, when the heart is beating very fast, these two tend to come very close to each other. In that way, we may even get a single sound, and that is known as summation gallop. The question will be asked to you, summation gallop is heard in which condition? Tachycardia. In tachycardia, S3, S4, they tend to superimpose on each other, and that lead to. Okay. So now you can see the picture nicely. S2, S3, S4, diastole, S1, and it just produced before the S1, so we call as pre-systolic. It's because after that systole starts. Simple diagram. S3, S4. Now look into this. Heart rate is 60. S3, S4. Agreed. Now the heart rate is 80. S3 and S4. They are coming to little near. Heart rate 100. S3, S4. And 120. They are quite near to each other. So what you notice, as the heart rate is S3, S4, S3, S4, S3, S4, and S3. You can see they are coming, as the heart rate is coming more and more, they are coming near to each other, and finally a time comes when they impose on each other. Quite near to each other, but when we auscultate, then you get a feeling of a single sound, and that is known as superimposed. So friends, again, they were all to explain to you, the only carry home message is this. Summation gallop is nothing but S3, S4 superimposed during tachycardia is summation gallop. Okay? Yeah. Now, let me give you a comparative chart of S3, S4. Filling mechanism is passive active. You remember? Third sound produced was simple. The ventricles are dilating. 70% of the blood is coming to atria, so it's a passive. But S4 is due to atrial contraction, atrial kick. That's why in atrial fibrillation it disappears. Because there is no active atrial kick, S4 will go away. Diastolic period early and late, that we know that S3 is early diastole and S4 late diastole. Ventricle cavity size is increased whenever third sound is getting produced. It is decrease or stiffness of the valve of the ventricle wall is the main criteria. Ventricle size is usually stiffness is there, then it may be reduced also. But one thing is stiffness is more important. Ventricular pathology is dysfunction or volume overload, is hypertrophy or anything ischemia is the basic pathology. Okay, ventricular dysfunction or so-called LV failure or hypertrophy or fibrosis or ischemia. That is the reason why S4 is getting produced. But the one thing is there, stiffness is the main reason. So these were all the S1, S2, S3, S4. Now I'm going to talk about opening, snap and clicks. One thing is basic concept. The basic concept is that normally opening of the valves, any valve, maybe mitral, maybe tricuspid, maybe aortic or pulmonary, opening valve produces no sound. No sound is produced in opening. Closing produces a sound. S1, S2 we know, but normally no sound. But what are these? But in certain condition, we can get sound in opening also. So let us see. So we have a first is opening snap. This is due to opening of the AV valves, particularly mitral valve. It's a high pitched sound in mitral stenosis, okay, and this is the valve is pliable and is not calcified. This can be seen both MS and TS. That's why I wrote the term as AV valve. But in the exam, whenever they will talk about opening snap, they will talk about only mitral stenosis. But at the back of the mind, you should know that this can be heard in tricuspid stenosis also. But since it's not asked in the exam, so I'm giving more weightage to the mitral stenosis. Importance, it is not calcified. Right? Why it is getting produced? This is the mitral valve, and we know the basic pathophysiology of mitral stenosis is increased LA pressure. Increased LA pressure is the hallmark. So when this valve in diastole opens, the pressure here is very, very high. Very high pressure is there and your valve is open by diastole. Atria also pushes a great effort. With the result, the valve opening is with a great pressure and that produces the sound. One example of what I always give in the class, that you are sitting in the room and somebody is coming to enter your room. He opened the room very quietly, no sound is produced, he can come. But he may come he may just push the door very fast. So definitely it is going to produce a sound because it has been opened with a great pressure. Exactly same theory. High pressure in the atria produces the opening snap, so-called opening snap. But what is important to remember is a high pitched sound. Okay, so you can see this is the you can see opening snap just after the opening of the mitral valve. Click. So we use the term click for the aortic and pulmonary valve. Snap, opening snap we use for opening of mitral and tricuspid valve. But same high pressure in the ventricles. Now in the previous one, opening snap was high pressure in the left atria or the right atria, and they are opening the valve with a great pressure. Here great pressure in the ventricles, that is and now the opening of the aortic and pulmonary valve will produce a sound, so-called ejection click, due to opening of aortic and pulmonary valve, high pitch. One thing is there, opening sounds are high pitch. They are heard just after the first sound. Okay. So in fact, in diastole we got opening snap. This we will get in systole. So they are just correlation to diastolic sound for opening of aortic, but these sounds are produced in the systole. And remember, opening snap, they were in diastole. Opening snap were in diastole. These are in systole. And again, they indicate flexibility. Because flexibility is there. The way we have flexibility in opening snap, we have flexible mitral and tricuspid. Here we are getting flexible, especially aortic and pulmonary valve. This is the ejection click. Okay, nobody going to ask you. So we get ejection click in aortic stenosis and pulmonary stenosis are the two conditions we are getting. One thing is there. All these opening sound are being produced by the stenosis. Opening MS, TS, PS and AS. And all these are high pitch sound. Okay, all these are high pitch sound. But now we have something mid-systolic click. It is non-ejection click. This we see in mitral stenosis, a very commonly asked question. So we are getting a S1, S2 and mid-systolic click. Mid-systolic click is what we see in mitral valve prolapse. And just to inform you that aortic and pulmonary click, and pulmonary click we see in early systole, and this opening snap we get in early diastole. So now beautifully you can locate this is mid-systolic click in MVP, and this we get in MS and TS. So friends, this is a beautiful summary of the entire clicks and snap in just one go only. So now one more thing, during this discussion we learned about some of the high pitch and low pitch. Let me clarify. All the high pitch sound are best heard with the diaphragm of stethoscope. In fact, traditionally when we auscultate the patient, we use a diaphragm for all purpose. But we can very well turn around the bell also. And that bell is used to hear the low pitch sound like S3, S4. So if now in the exam the question will be asked to you, there's one patient who has got mitral regurgitation and you want to hear the additional sound. And to hear that additional sound, what are the important precautions you will take? Number one, you will ask the patient to turn around left decubitus position, which you did yourself also. And I told you to do it tonight when you are sleeping, turn around left decubitus position. Second thing, what examiner want to know, that you have to change into bell from diaphragm, and then only you have to auscultate at what place it is. Suppose we are talking about mitral, okay, then you have to listen to in the mitral area. Aortic in the aortic area, pulmonary in the pulmonary area, that I told you. Okay. So friends, ejections. Now what are the systems? So this is a summary of what a use of diaphragm and the bell. Now let us see let me give you summary. Systolic sound, we are getting ejection click, high pitch. S1 is high pitch. Diastolic sounds, S2 is a high pitch, S3, S4 are low pitch. Opening snap, high pitch. Pericardial knock, high pitch, and I told you pericardial is a high pitch and S3 is a low pitch. Tumor plop is a low pitch, which resemble like opening snap, but its pitch is low. So now you can understand that if you have to differentiate tumor plop from opening snap pitch, this you will see with the bell, and otherwise is diaphragm. So now you can see the importance of low pitch and high pitch. A quick recap about a heart sound. Loud S1 is seen in MS, TS, tachycardia, short PR interval. Soft S1 bradycardia, mitral valve calcification and MR. Single S2 tetralogy failure, truncus arteriosus, pulmonary atresia, tricuspid atresia and Eisenmenger syndrome. Soft S2 aortic and pulmonary wall calcification. Wide variable RBB. Wide fix is ASD. Reverse or paradoxical splitting is ALBB and aortic stenosis. Third sound can be heard normal in physiological condition like children, athlete and pregnancy. It can be pathological in coronary artery disease, congestive heart failure and mitral regurgitation. Pericardial knock, the most important, constrictive pericarditis. S3 is never heard, and in MS and cardiac tamponade, these two are the most important question that you should remember. Fourth sound, pre-systolic or atrial sound, never physiological, seen in hypertension, AS, HOCM and CAD. All these you have to remember. Opening snap, TS, MS. Ejection click is AS, MS. In MVP, you get non-ejection click. Well, a lovely, beautiful summary. You love to see this. This I'll spend time. Sound due to abnormal ventricle. S3, S4. You can see. Sound due to abnormal pericardium. Pericardial knock. Sound due to abnormal valve. Aortic and pulmonary ejection click. Mitral valve click. Okay. Then opening snap. They're all due to abnormal valve. And sound due to abnormal atrium is tumor blob. It's beautiful summary. So, other than the routine sound, abnormal ventricle, abnormal pericardium, abnormal valve, and abnormal atria. Right? This is a summary of the abnormal sounds. Now I'll be talking to you regarding jugular venous pulse. What is the normal height of JVP? It is 6 to 8 centimeter of the blood. This is the mistake students do. They usually talk about 6 to 8 millimeter of mercury or something. Best answer is blood. Why? Because whenever we measure the height, of course we measure the height with the patient inclining at 45 degrees centigrade like this. And we try to locate between the two heads of the sternocleidomastoid, two head of sternocleidomastoids, and right, that we see. But nobody is going to ask you this question, but positioning is important. What is important? I said 6 to 8 centimeter of blood. So when we are measuring this height, we are measuring the height of the blood. In actual practice, we are not measuring height of water. And the common mistake is they will ask questions 6 to 8 centimeter of blood, 6 to 8 centimeter of water, 6 to 8 millimeter of water or millimeter of whatever different is 6 to 8. And one more thing, when we talk about actual JVP, the height we take from the right center of the right atrium. Center of right atrium to the upper border of the JVP is what we call as 6 to 8 centimeter. But otherwise, in actual practice, when we measure, we take from the sternal angle. That height will be less. That we take as 3 to 4 centimeter of the blood. That's the basic concept. Now, one thing what we learned was 6 to 8 centimeter from the right atrium. Yeah. Now let me talk. Well, when we are looking at in the left in the neck area, we get two pulsation. One is JVP, and we also get systolic pulsation. The first thing is we should be able to differentiate between the two. So how to differentiate JVP from the carotid pulse? The mnemonic is pulse. P for palpation. JVP is non-palpable, and I don't need to talk to the illustrious student listening to me. Carotid we can very well palpate. Occlusion, it is really occludable. You can press it in the vein. You can find it will disappear. But carotid is not occludable. Location, it is located between the head of sternocleidomastoid and between the two head of sternocleidomastoid, it lies lateral to carotid. Carotid lies medial and this lies lateral. Inspiration, there is a fall of JVP in inspiration. Carotid doesn't change with inspiration. Contour is a biphasic waveform. In contrast, when we talk about carotid, it's just like an outward thrust. And finally, position, it drops when sitting erect. Carotid level doesn't fall. Okay, so these are the mnemonic: pulse, palpation, occlusion, location, inspiration, contour, and erection or position. With this background, we find that it's again what I told you. It's a waveform. It comes like a waveform. Right? Now comes a very commonly asked question. So we get a type of pulsatile type of JVP. And classical question, non-pulsatile JVP. Non-pulsatile JVP. That means you are not getting any pulsation in JVP that we see in any condition which lead to superior vena cava obstruction, and that is very commonly seen in lung cancer. The non-pulsatile JVP is seen in superior vena cava obstruction, which is seen in lung cancer, a very commonly asked question. So now I'll be talking to you regarding different type of waves that we get in JVP. We'll take one by one. First, we learn the normal physiology. A wave. This is produced due to atrial contraction. And definitely it will produce just after P wave in JVP. In ECG, P wave is produced due to atrial contraction. So it will correspond to S4 in the heart sound. It corresponds to P wave in ECG, S4 in heart sound, and it just occurs just before the first heart sound. Okay, now look into this. This A wave is getting produced, and it is when there is S4. S4 is there, and S4 occurs just before the first sound. So it is a positive pre-systolic because it's occurring before the systole, near the end of diastole. Okay, produced near the end of diastole. So-called pre-systolic sound S4. This is A wave. Right? Now let's talk about C wave. C wave is produced due to bulging of tricuspid valve into right atrium during right ventricle isovolumetric systole. Before I go, let me tell you about the cardiac cycle. Little bit more about this, the tricuspid. So we all know very well that before the ventricle actually has systole, before the systole we have a condition so-called isovolumetric systolic period is there. What is that period? It is this period when all the valves are closed. All the valves means tricuspid, pulmonary, aortic and mitral. All the valves are closed. Ventricle muscle are contracting, but they are simply pressure is getting generated. All the valves close, and this a very brief period is so-called isovolumetric contraction is there. So everything is closed and a huge pressure is getting generated in the right ventricle. During that time, this tricuspid valve will slightly bulge into the right atrium, and that bulging will produce C wave. So just you can see C wave is getting produced in the time when a trach valves are closed. It corresponds to S1, right? Bulging or tricuspid valve into the atrium in the isovolumetric state. This is correspond to S1. X descent. Well, now this was a A wave and we got a very short period of C wave. After that, this X descent is coming like this. It is a negative wave. Going down is negative wave, definitely. Now why it is getting produced? During A wave, the atria has already contracted and pushed the whole blood into the ventricle. Or I can say there was an atrial systole near the end of diastole when the atria has pushed blood into the ventricle. Then of course atria will have a diastole, and diastole atria will expand and atria will relax. During that time blood is coming, and moreover downward displacement of closed tricuspid valve during the ventricle systole. Now the ventricle systole is actually occurring. The tricuspid valve goes down. Point to be noted, when in the isovolumetric state, when the ventricle was about to contract but all the valve closed due to pressure, it went up and that produced the tricuspid valve went up and that produced C wave. But now during the actual ventricle systole, this valve come down. So valve come down and atria are dilating, so that the descent, that pressure will reduce, that produces the X descent. Okay, so you learn, so it's a negatively systolic wave being produced when the ventricle systole is occurring, and it is downward flow is there. V wave, well, ultimately increased amount of blood is coming into right atrium during ventricle systole. Initially it went down, now more and more blood is coming, the pressure start rising again. So now more in atrial diastole. Remember, I'm talking about atrial diastole or atria is relaxing, is getting more and more blood. More and more blood will generate a type of V wave. Okay, and of course in isovolumetric relaxation phase, tricuspid valve is closed. That will again contribute to more and more blood into the ventricle or into the atria, that produces V wave. So it is due to, now this most simplified version, it is due to filling against the closed tricuspid valve. The beautiful mnemonic is willing. V for V wave, F for filling. The beautiful mnemonic is willing. So during atrial filling, more and more blood filling is what we call as willing. Sir, can you give you are going to ask me, sir, can you give me a example, day-to-day example? Yes. This is a swimming pool. Oh, nice. Swimming pool. Water is here. And you jump. I'm sure many of you do swimming. You go to swimming pool, you jump. You go deep into this. Fine. And once you go, of course, by default, you come out also. I think you got the answer what I wanted to convey. This is X, this is V. Very simple. X and V, negative and positive. Okay, I don't think you are a swimmer, you know what I wanted to convey message. Yeah, it corresponds to S2. Okay, so now you have to remember what corresponds to S3 was, S4 was A wave, and this thing. Then we talked about C wave was S1. Then we talk about V wave is S2. And now let's talk about Y descent. And this is due to opening of the tricuspid valve. Rapidly blood flows into the ventricle and that produces Y descent, and that is the correspond to third sound in the left ventricle. So look into this. Y descent is there, again a negative wave, right? So this is a beautiful summary. You can correlate. This is third heart sound. First is C, 2 is V, 3 is Y descent, and 4 is A wave. You should remember these also. So important point, A, C and V are positive wave, X and Y descent are negative wave. With this background of the normal physiology, now we talk about abnormality of JVP. Raise JVP with normal waveform is one of the very important point of right ventricle failure or volume overload. In fact, it's one of the important diagnostic criteria of right ventricle failure, to be more precise, and these are the patients who will be needing diuretic therapy. Okay, simple. Right ventricle failure, diuretic therapy will be needed. Raise JVP without pulsation, I mentioned to you earlier also, so-called superior vena cava obstruction. And if it's simple, if you happen to get one patient and if you can pick up this finding like this, simple, you can straight away think about that we are dealing with a case of lung cancer. Okay, such an important sign. Now, to this, when you will think like this, whenever this superior vena cava obstruction will be there, additional finding that we will see in these cases will be, other than the non-pulsatile JVP, there will be prominent upper chest vein, upper chest veins. You will find the upper chest veins are very prominent, with additional feature that by which you can pick up that we are dealing with superior vena cava obstruction is there. Now, large A wave, you will get in tricuspid stenosis. Definitely, there is a atria contracting against this narrow valve. It will lead to prominent A wave. Pulmonary stenosis and pulmonary arterial hypertension. In all these conditions, you will be getting large A wave. But Cannon waves, that means very, very prominent A wave. When the atria is totally contracting against a closed closed, when the right atrium is contacting against a closed tricuspid valve, that means the whole pressure will go upward, and that we call as Cannon A wave. And now you can imagine, look into, I can give you a comparative chart. This is the normal A wave, we get it. Normal A wave like this. Normal A wave. But here we are again normal A wave, but here we are getting a like this thing. This, you can see, is a huge wave, just like a bomb is fired from a cannon, and that is so-called Cannon A wave, what we call as. This is seen in any condition which lead to closed atria contacting against a closed tricuspid valve, complete heart block, junctional rhythm, and atrioventricular dissociation. But this is the most commonly asked question. These two, sprightly junction or complete heart block. Absent A wave, you can see A wave absent, that we see in atrial fibrillation. Giant V wave, that we see in tricuspid regurgitation. We know the basic physiology. In V wave, we are getting blood from the ventricle. Okay, we are getting blood in the ventricles. Okay, so more in tricuspid regurgitation, blood is coming. More and more blood will coming from the ventricle also. That we will be getting a prominent V wave is a very, very important sign for tricuspid regurgitation. Okay, so you can see prominent V wave. This the normal V. You see normal V wave, mild and severe. So you can see the beautiful comparative picture also. I can remove this thing. You can compare this V wave, different V wave. V wave, normal, mild and severe. See the height that we are getting it. Slow Y descent is seen in tricuspid stenosis and tamponade. This is very, very important. Y descent is never prominent in cardiac tamponade. Slow Y descent is there, right? Prominent Y descent. Y descent is very prominent. This we see in constrictive pericarditis, right heart failure and high venous pressure. Well, we know very well the Y descent is produced due to opening of the tricuspid valve. So prominent, and you are getting low, slow Y descent, we are getting it. Prominent X descent. X descent we are getting normal, and we are getting more prominent in constrictive pericarditis, cardiac tamponade, tricuspid stenosis and right ventricle failure. In all these conditions, you get prominent X descent. X descent is absent in tricuspid regurgitation. Abdominojugular reflux. First of all, it is reflux. It is not reflex. It's not reflex, it is reflux, because the blood is going backward is reflux. What we do and how we do, again, we ask the patient to lie at 45 degrees. Okay. And you put a sustained pressure on the right hypochondrium, the way it has been put into this thing. Right hypochondrium, and you are looking at the JVP. So you press for 10 seconds in the mid-abdomen as I showed to you, and JVP will rise, and you measure the height when it is in the peak. Now you leave your hand. There will be fall of 4 centimeters of blood. That means you can even other way around. In the normal, you measure JVP. You put a pressure, it goes high. You can measure that time also. You release, come back. If this fall is more than 4 centimeter, this is positive hepatojugular reflux. And this indicate incipient right heart failure. Okay, incipient means right heart failure is about to occur. So it will done in only those conditions where we clinically think the patient has right ventricle failure, but JVP is not raised. So we are artificially raising the JVP, and if it is there, it's a positive refluxes there. Will you do in a very full-blown right ventricle failure? There's no point. It's already there. There's no point in doing in full-blown right ventricle failure. It's only for incipient. Incipient means it may be there. Okay. A quick recap. The A wave produced due to atrial contraction. C wave, bulging of tricuspid valve into right atrium during right ventricle isovolumetric systole. X descent due to atrial relaxation and downward displacement of valve during ventricle systole, proper systole. V wave, increased volume of blood in the right atrium during ventricle systole. Y descent, opening of tricuspid valve, that lead to Y descent. Raised JVP with normal waveform is right fluid overload and right heart failure. Raised JVP with non-pulsation is superior vena cava obstruction. Large A wave, tricuspid stenosis, pulmonary stenosis and pulmonary arterial hypertension. Canon A wave, complete heart block, then junctional rhythm and AV dissociation. Absent A wave in AF and giant V wave in tricuspid regurgitation. Slow Y descent, tricuspid stenosis, cardiac tamponade. Prominent Y descent in constrictive pericarditis and severe right heart failure. Prominent X descent in cardiac constrictive pericarditis and cardiac tamponade. And abdominal jugular reflux is seen in right-sided incipient heart failure, heart murmurs. So first of all, let's learn the definition of heart murmur. There it results from audible vibrations. Audible vibration. Okay, that are caused by the increased turbulence and defined by their timing within the cardiac cycle. Okay. Well, one thing is there, they are vibration, and that we can auscultate with the stethoscope, right? If I have to give you a day-to-day example, well, we have a mobile, and in mobile, when you are sitting in a meeting, in a conference, most of they ask you to keep it silent in the vibrator mode. Okay. You take your mobile, you put in the vibrator mode, and you put in your pocket. Let your friend give a call to you. Now this phone will vibrate in your pocket. Oh, now you can feel in your legs. Oh, phone is vibrating. And if you can keep your stethoscope, I am not asking you to keep stethoscope. You can hear a sound. So that is a type of murmur. You can say it's simple, as simple. You try this. You can try this also. Anyway, this is only for those who are undergraduate students. The idea is to tell you it's the audible vibrations. Day-to-day example. Why? Caused by some turbulence in the blood flow. Well, we have been studying that blood is coming, going, it's all smooth, normal, no disturbance. But whenever there is some disturbance to blood flow, so in some turbulence will be there. This is what murmur, and we define by timing within the cardiac cycle, whether it is in systole or diastole, It is early, mid or late, all accordingly we define the murmur. But carry home my message, just to understand subject is a type of audible vibration and how to feel, that I give you example also. So now various types of murmur are there. Early systolic, the one which is really not known to 99%, believe me. VSD with PAH, unbelievable. VSD, sir, we get pan-systolic murmur. Yes, you get. But here it is VSD with PAH, or we can write that other way around like this also. Same thing, Eisenmenger syndrome. So VSD with reversal of shunt, you get early systolic murmur. VSD with very small VSD, very small, again will produce a early systolic. And one thing, early systolic murmur is a feature of tricuspid regurgitation. Point to be noted. Occurring in the absence of pulmonary hypertension. There is TR, but there is no PAH, and is seen in drug abuser, of narcotic abuser with infective endocarditis. Friends, these are the rank number 1 getting question, or top rank question are these early systolic murmur. Mid systolic, this is known to all of you. Ejection systolic murmur we see in AS and PS. You can see S1, S2, and you are getting a ejection systolic murmur. This is easy, known to all of you. Late systolic murmur, you can see the click, MVP, and you can also get in papillary muscle dysfunction. These two are very frequently asked question in the various exam. You can see S1, this click means mitral valve collapse. In papillary muscle dysfunction, murmur will be there, but there will be no click. Pan-systolic murmur is a universal question. MR, TR and VSD start from S1, goes to S2. Quite often it maybe this is a A2, P2. Quite often it can merge with the A2 also. A2 also. You may not be able to hear pulmonary component or aortic component at times, but pan-systolic murmur, MR, TR and VSD. Early diastolic in AR and PR that start after second sound, aortic and pulmonary regurgitation, early diastolic murmurs are there. You can see. Mid diastolic murmur, MSTS, is known to all of you. But Carey-Combe murmur, Austin, Flint and Graham Steele, these three are also mid diastolic murmur. This we see in acute rheumatic fever. This we see in aortic regurgitation, and this we see in pulmonary regurgitation. But one thing I like to highlight, they are named murmur. All named murmur are diastolic. This is a very important point you got to remember. So Carey-Combe murmur, Austin, Flint, Graham Steele, all are named. They all are diastolic murmur. And we may also get a murmur in atrial myxoma. Atrial myxoma is a LA tumor, and this is the LA mitral valve, and this LA tumor is there. So it can come and obstruct the mitral valve. So they can produce a functional type of mitral stenotic murmur, but it is a low pitch murmur. What will be produced by low pitch murmur will be produced by the myxoma in murmur of MS is a high pitch, and moreover you change the position, this murmur may disappear. So this is a classical example of so-called opening snap in mitral stenosis, and you are getting a type of mid-diastolic murmur. Now let me talk about Carey-Coombe murmur. It is a low pitch mid, or sometimes it may be delayed diastolic murmur. Murmur of mitral stenosis as such is a high pitch, it's low pitch, and this is due to increased diastolic flow secondary to MR in acute rheumatic carditis. We know very well that in rheumatic, MR is the very common finding, acute rheumatic fever, heart, and we are getting a MR murmur in acute rheumatic fever, blood goes to the left atria. In the next diastole, a large amount of blood come back in the ventricle, and that produces a murmur, functional murmur, so-called Carey-Coombe murmur. Remember, same thing in adults. If same thing happens, this produces S3. So now you are definitely going to ask me a question. You mean to say third sound is getting produced due to same reason in MR in adults? So why can't you comment about S3? Well, basic concept, S3 is heard normally in children also. And one more thing, acute rheumatic fever is a disease of the 5 to 15 years. In this age group, S3 is already there. So that's why we don't comment about S3 in children, but we definitely talk about Carey-Coombe murmur. A specific name is given in acute rheumatic carditis. Late diastolic murmur can be heard in atrial myxoma. I told you this can be mid or this could be late diastolic murmur is there. Continuous murmur is heard in PDA, very, very important. Coronary, pulmonary AV fistula and systemic AV fistula. This I will talk. If I ask you, where do you see this? The best example is if you have seen any patient of chronic renal failure who is undergoing dialysis. In them is always they make a AV fistula. Most of you must have heard, seen it, and if those of you who have not seen, try to see any patient. If you get a chance to visit any dialysis ward, every patient will have a AV fistula. You just keep your hand over the AV fistula and you can hear this. You can even palpate it. Okay, you can palpate it and you can auscultate for a continuous murmur. This is the best example I can give to you. ASD with MS, so-called Lutem-Bascher syndrome. Again, a very commonly asked question. So many patients of ASD may develop MS, mitral stenosis in due course of time, so-called Lutem-Bascher. But again, one more question. In this, ASD is congenital and MS is acquired. Again, a very commonly asked question. MS is acquired and ASD is congenital. In coarctation aorta, also you may get a continuous murmur. Pulmonary embolism and rupture sinus of Valsalva can also produce a continuous murmur. For exam point of view, this is the single most important and this is the second most important. Don't forget these two, PDA and systemic AV fistula. Changing character of murmur. This we can see in infective endocarditis, atrial thrombus or atrial myxoma. But this is the one which is most commonly asked. This is second common asked question. Changing character. Of course, they write as moment to moment. It's never moment to moment. The moment to moment possible only in atrial myxoma. Okay. But endocarditis, yes, changing doesn't occur. Why I say in atrial myxoma, patient lying supine, you auscultate, you get a murmur, you make him sit, it may disappear. This may occur moment to moment. In fetal endocarditis, changing cato murmur does occur, but it's not that you lying supine is different, standing different. It's not so early, but yes, it is a changing cato murmur. They do discuss, yes, it can happen. Memory souffle is an innocent murmur heard over breast in pregnancy because of in pregnancy. We all know there's increased vasculature of the breast and that can hear some sound. Venous hum again heard in pregnancy in the right supraclavicular area. Right supraclavicular area again due to increased blood flow. Memory souffle and venous hum, both in pregnancy. This is very, very important. Dynamic auscultation is effect of physiology or pharmacological intervention on murmur. At time you are auscultating, you are not sure whether I'm listening to the murmur of MR or TR, whether I'm listening to the murmur of MS or TS, confusion may occur, especially in those patients who have a small build. Then we do certain maneuvers, so-called dynamic auscultation is there. One of the best and the easiest is to do the respiratory changes. We ask the patient to take a deep inspiration like this. Then you ask the patient to deep expiration. Okay. Well, all the students try, take a deep breath the way I'm taking. Yeah. So if the way you have taken a deep inspiration, all right-sided sound and murmur, they increase in inspiration. And the way you exhale, all left-sided sound and murmur, they increase in expiration. But to this rule, there is only one exception, that's pulmonary ejection click. This is a right-sided sound, but its intensity increases on inspiration. Okay, it decreases or during inspiration. It's a right-sided sound, its intensity decreases on inspiration, is the only exception to this rule. But why this happened, reason not known, but it is there. This is a very, very important exam question, and in any practical exam, this you should, when you are listening to a murmur, you must document and tell the examiner that this I have done it. Examiner will be very happy that you know about concept of dynamic auscultation. Second is Valsalva maneuver. For exam point of view, this is the single most. Valsalva maneuver, which is you are having a forceful expiration against the closed glottis. Look at me now, look at me. Yeah. You try to exhale against the closed glottis. And in this, when you are doing it, you will be feeling pressure in the anal area. This is one way. We tell the patient also. So this is a Valsalva maneuver. All the murmur, they decrease in length and intensity except HOCA and MVP. This you have to remember. One of the most important thing is HOCM and MVP are the only two murmur which increase in intensity on standing and standing and Valsalva. So these two murmur, they increase on standing, position change in standing and Valsalva. So HOCM and MVP murmur increase on standing and Valsalva. So a quick recap of the LMRP. Early systolic murmur are VSD, PEH, very small and tricuspid regurgitation. Mid systolic are AS and PS. Late systolic MVP and peppery muscle dysfunction. Pansystolic MR, TR, VSD. Early diastole AR, PR. Mid-diastolic MSTS, Carey-Combe, Austin Flint and Graham Steele, all named murmur are diastolic. Atrial myxoma can have mid and late diastole also. Continuous PDA, VSD systemic with MS and systemic AV fistula. Changing character of murmur we can see in endocarditis, myxoma and atrial thrombus. Memory souffle heard over the breast in pregnancy and venous hum over the heard in pregnancy over the right supraclavicular area. Respiration, all right-sided sound and murmur they increase on inspiration, and all left-sided sound and murmur they increase in expiration. The only exception is pulmonary ejection click. Valsalva and standing position, the only two murmur increase, MVP and HOCM, rest all decrease. Thank you very much. God bless all of you.